So, as it is pretty evident from the title card over here, our topic of discussion today is respiratory pharmacology. That is, we will be dealing with all those drugs which are linked to the lungs, the bronchioles, the upper and the lower respiratory tract. And since a drug is something that we do not consume normally, we only consume drugs, or rather medical drugs, we only consume them when we are under some kind of a stress, we are under some kind of a problem, there is some kind of a disease, right? So when we are saying that respiratory pharmacology will be dealing with the drugs of the lungs and the bronchioles, we have to specify as to what condition, what problem we have in the lungs. So a very common problem, a very common airway disease is asthma, right? And primarily in this discussion, we will be talking about the drugs dealing with asthma. Okay. Now let me tell you something. The respiratory pharmacology, it can be very roughly divided into two sections. One is regarding the drugs related to asthma, which we'll be discussing right now, and the other is a much shorter topic, that is the drugs related to cough. Okay, antitussives, mucolytics, all those drugs, and there isn't much to talk about them. It's more or less a memorization thing, but we'll make a video on that as well, and that will be a much shorter video than the one which we are currently going to be pursuing. Then the topic is asthma. Okay, so we'll be dealing with the drugs used for bronchial asthma. So the thing is, we have to understand what this condition actually is, very roughly. Obviously, we are not studying pathology. If this was pathology, we would have gone for a much more detailed talk on the condition itself. But from a purely pharmacological perspective, if we are to narrow down what asthma is, then asthma is primarily, I would say, let's go with this. Asthma is primarily an inflammatory condition, or rather it's an inflammatory response. Inflammatory response to what? You're responding to something. What are you responding to? It can be a number of stimuli, right? It can be cold, it can be some kind of allergen. What exactly is your response? Your response is narrowing of air tubes, that is the bronchioles, alveoli. Then your response is also going to be increased mucus secretion. Your response is also going to be mucosal edema. So these are more or less the response shown by the respiratory tract. To what? To a number of stimuli. And what kind of response? Inflammatory response. This word inflammatory, dealing with inflammation. Obviously, we will be studying inflammation in a lot more details when we will be talking about pathology. Obviously, there is an entire chapter of inflammation there. But considering that you have some basic idea of what inflammation is, I would say it's pretty self-explanatory as to what asthma is then. It's an inflammatory response to a number of stimuli which leads to narrowing of the air tubes, increased mucus secretion, mucosal edema. And what would all of these lead to? What are the clinical effects of this? This would lead to difficulty in breathing, which is dyspnea, right? Then it might lead to wheezing. These are the effects of asthma, right? Difficulty in breathing, wheezing. These are more or less the effects that are seen in asthma. And what I mean by stimuli, let's write that down as well. the stimuli that can be infection, some kind of pollution, exercise, infection, can be exercise, can be any kind of allergen, because asthma is an inflammatory response. It's a hyperreactivity reaction, actually, a type 1 hyperreactivity reaction. Type 1 hyperreactivity. Okay. So if you don't know anything about inflammation, if you don't know anything about allergies, if you don't know anything about hyperreactivity, then I would say that for now, just understand this, that obviously everybody has some basic understanding of what allergies is, right? Or rather what allergies are. So allergies are this very extreme reactions that our body shows to some very specific kind of stimulants, right? Since it is some extreme kind of reaction that our body is showing, it is called a hyperreactivity. What kind of hyperreactivity? Type 1. There are majorly 4 types of hyperreactivities. Type 1 hyperreactivity is allergy. Anyways, all of this will be dealt with in much details in other subjects. But the thing is, it's an inflammatory response to a number of stimuli, which can be infections, exercise, some kind of allergen, right? Which leads to all of these things. So this is more or less the definition of asthma. Now I said that it is a type 1 hypersensitivity reaction. If you have some understanding of what a type 1 hypersensitivity reaction is, right now it's beyond the scope of our discussion, but I'm assuming that you have some understanding of what type 1 hyperreactivity is, type 1 hypersensitivity reaction is, then you would know that type 1 hypersensitivity reactions are mediated by IgE antibodies. A very, very, very important thing. Type 1 hypersensitivity, it is actually mediated by IgE antibodies, and since asthma is a type 1 hypersensitivity reaction, so it is also mediated by IgE antibodies. Now, since we are to talk about the drugs which we are going to use for treating bronchial asthma, we have to understand how we are going to approach this disease, this condition of bronchial asthma. For that, we need to understand a little, very little, about how actually asthma is brought about. That is, a little about the, you might say, pathology, a little about how this asthma is coming about. So how it actually occurs. A little, just a little. See, the entire pharmacology, let me tell you something right now. Entire pharmacology, whatever systemic pharmacology topic you study, it's basically dealt with in a certain way. You first understand the pathophysiology, that is what exactly is happening. Then you go for how you are going to deal with that pathophysiology, right? So in this case, in asthma, what's happening? Listen to me very carefully. See, in the airway system, we have certain mast cells. Let's draw the mast cells. Suppose these are mast cells. Okay, they have granules within them containing a number of chemical mediators, right? So suppose this is a mast cell. Okay. Now what is happening is, when we are actually having some kind of an exposure to some kind of allergen, some kind of an antigen, suppose. So suppose, let's draw it with yellow. Suppose this is the antigen. Okay, this is the antigen. We are getting exposed to that particular antigen for the first time. Okay. Now, when first time antigen exposure is happening, what is happening is These mast cells, they actually have IgE antibodies. Suppose this is an IgE antibody, IgE antibody. These IgE antibodies, which are produced in response to the antigen, they will bind to the mast cell. First time exposure we are getting of the antigen, IgE antibodies produced in response to that antigen, these IgE antibodies will bind to the mast cell. First time. Now, second time, when the same antigen is again getting exposed for the second time, what's happening then? These are the granules, and the IgE antibodies, they are already present, right? Already present. Second time when the antigen is getting exposed, or second time when we are getting exposed to that particular antigen again, what is happening is that antigen will bind with the IgE, which is already bound to the mast cell. Okay, it will bind to the already bound IgE on the mast cell on second exposure. This in turn would lead to what we say to be a degranulation reaction. It's a fancy name, but it's pretty simple to understand what it is. It means that the granules within the mast cell will break down. So, what will happen? It will break down and it will release its chemical things, chemical structures, the chemical things which were in there, within the granules, right? So this is the degranulation step, degranulation of mast cell. So these chemical mediators, they are chemical mediators of what? They are chemical mediators of inflammation. Because if you remember carefully, provided that you know a little bit about inflammation, inflammation is brought about by certain mediators, right? Chemical mediators. So these chemical mediators, leukotrienes, then histamine, these are the chemical mediators of inflammation. They are stored in these granules of mast cells. They are released into the, they are released outside. So they will bring about inflammation reaction. And since this entire thing is happening in the airway, the bronchioles, so it would lead to an inflammatory reaction in the airway region. And this would actually lead to what we say to be an type 1 hypersensitivity reaction, which is asthma. So this is very roughly speaking, very roughly speaking, this is how this type 1 hypersensitivity reaction, which is an inflammatory reaction, which we are saying to be asthma, this is more or less that. Now, if I am to be a little more specific on the chemical mediators of inflammation, the most important chemical mediator of inflammation in this case, that is in asthma, it is none other than leukotrienes. Now, we will come to know later that leukotrienes are very potent bronchoconstrictor. And that is why, more or less, why we see such potent bronchoconstriction in the alveoli and the lower bronchioles in asthma. So this is more or less how asthma is occurring, more or less, very roughly speaking. Obviously there is a lot to this. So why should I know this? Or rather, more importantly, the question over here is, why am I discussing this in a discussion which is primarily focused on pharmacology? This is a pharmacology discussion, right? Why am I talking about these things? This is a pathology thing. Because now when we will go into the approach to asthma, that is how we are going to approach this condition, or rather treatment approaches, the approach to treatment, what we are going to do is we are going to take individual steps from over here, and we are just going to use drugs which would either antagonize that particular thing or it would inhibit that particular thing. For example, see, I said that these are IgE antibodies, right? Suppose I provide a drug which can prevent this antigen from binding to the antibody. So drugs which can prevent the antigen antibody reaction, they can prevent this entire cascade of reactions, and they can in turn prevent asthma. So that can be an avenue of treatment. Then again, I can also make drugs which are going to prevent the degranulation of mast cells by making the mast cells strong enough so that they will not degranulate easily. That would also help in treating asthma. Or I can make drugs which are leukotriene antagonists. They will antagonize leukotrienes, or rather they will either stop leukotrienes from being produced, or they will be leukotriene receptor antagonists and will not let the leukotrienes bind to their particular receptors. That can also be an avenue of treatment. So see, knowing about the pathophysiology of asthma on a rough basis has given us all the tools that we need for approaching the treatment for asthma, and that is why we need to understand how this condition is occurring. So now the discussion has become so much easier now because we know how asthma is occurring. What are the steps? So we just have to remember or recall the steps, and we just have to antagonize them in a kind of way, right? So approach to treatment, if I am to do this, see, we said that bronchoconstriction is the major thing that asthma is presenting itself with. So if we use drugs which can bronchodilate, that can be a treatment way. So either we use bronchodilators, or we use drugs which can antagonize leukotrienes. So drugs which are leukotriene antagonists, this is the antagonist sign, the hashtag leukotrienes, LT, or let's go a little up, leukotrienes, let's go a little up, degranulation. Drugs which can stop that, so drugs which can make mast cells strong, or in a fancy way we can say mast cell stabilizers, or another way is go a little up, yes, drugs which can prevent the antigen IgE reaction. So drugs which can prevent the antigen from binding to IgE. So drugs preventing antigen IgE, oh, this should be small, sorry about that, IgE reaction. So these are the four major avenues of treatment for asthma. This is more or less the entire chapter, right, individually. So if I am to actually go into a little more details of the treatment, I would say that under bronchodilators, how are we going to bronchodilate? This is where the knowledge of the autonomic nervous system comes in handy, and that is why I made that introductory video. Although a better way is to study autonomic nervous system pharmacology beforehand and then come to this, because autonomic nervous system is everywhere in systemic pharmacology. But for now, let's just try to adjust. So one way that we can bronchodilate is, see, there are a lot of ways that we can do this. We can use drugs which affect the autonomic nervous system, because try to understand this. Autonomic nervous system is that part of our nervous system which actually deals with all these involuntary actions and functions, right? Bronchodilation, bronchoconstriction, is this under our influence? No, we cannot voluntarily do them. So autonomic nervous system controls them. So sympathetic system, see, so easy to understand. Sympathetic system, what would sympathetic system do as far as bronchodilation or constriction is concerned? Which one would sympathetic system do? Sympathetic system would lead to bronchodilation, because I had mentioned in my previous video, sympathetic system is only sympathetic, that is, it only stimulates heart. All the other major organs, it relaxes, it down regulates, it relaxes. So bronchodilation. So if I actively agonize sympathetic system, I would get bronchodilation. But if I actively antagonize the parasympathetic system, then also I would get bronchodilation. This is a fancy way of saying that we can use adrenergic drugs and anticholinergic drugs. So this is one way that we can lead to, or we can cause bronchodilation. We'll come into the details of this in a bit. Another way of causing bronchodilation, see, there are a class of compounds which are known as methylxanthines. Methylxanthin, a very common example of methylxanthin is caffeine. Caffeine in coffee, tea, all those coca beverages, the coca beverages, the caffeinated beverages. So caffeine is a methylxanthin. Methylxanthins, they actually have a power of bronchodilation. How? We'll come into the details of that. But it's actually not caffeine which is a bronchodilator, although caffeine is a methylxanthin, but primarily the methylxanthin which is concerned with bronchodilation is theophylline. Theophylline. This is the major drug under methylxanthin, obviously, which leads to bronchodilation. How? We'll come into that later. Then, see, I had mentioned something about leukotrienes, right? Leukotrienes, they are chemical mediators of inflammation, right? The major treatment, the major anti-inflammatory treatment is administration of something which we say to be steroids. So steroids is another way by which we can treat asthma. But steroids, they are not actually bronchodilators. They do not actively bronchodilate like the adrenergic or the anticholinergic drugs or theophylline. These are active bronchodilators, but steroids are anti-inflammatory. Since they are anti-inflammatory, and since asthma is an inflammatory condition, that's why corticosteroids, they are a major drug source or drug treatment choice for chronic asthma. Okay, so this is also something that we'll be talking about later. So this is more or less the different avenues by which we can treat. So if I am to wrap this up, that approach to treatment, before we enter the details of each of these, if I am to wrap this up in a nice table like thing, let's make a table. So let's make it red, let's make it green, yeah. So asthma treatment. Okay, let's recap. What are the different ways in which we can do it? Number one, use bronchodilators. What kind of bronchodilators? They can be adrenergic, that is sympathomimetics. Let's write it down first and then I'll explain to you in a short bit. Sympathomimetics. Sympatho means sympathetic system. Mimetic. Mime. A mime is someone who mimics. So drugs which mimic the sympathetic system. That is, drugs which agonize the sympathetic system. That is what I had mentioned before. Now, sympathetic system itself has a number of receptors which I had mentioned in my previous video. The receptors of sympathetic system which are present on the lungs, they are beta 2. Beta 2 sympathomimetics. Since beta 2 sympathetic receptors are present on the lungs, so, or rather the respiratory tract, the bronchioles, you might say. So beta 2 sympathomimetics. Do not worry if you are not understanding this part crystal clearly right now. This all will be explained in a lot more details when we'll actually go into details of these individual things and also in the autonomic nervous system pharmacology, right? So beta 2 sympathomimetics. Another way of treating is you can give sympathomimetics, mimicking sympathetic system, or you can give anticholinergic, that is antagonizing the parasympathetic or cholinergic system. So what are we going to say? Anticholinergic drugs. Anticholinergic. Right. Now, which cholinergic receptors are present on the lungs? I had actually talked about a mnemonic to remember this. First you eat, then learn by heart, then do everything else. First you eat means the stomach. So M1, the muscarinic receptors, M1, they are present on the stomach and also the central nervous system. M2, learn by heart. So M2 is present on the heart. Everything else comes after that. That is, M3 is present on all the other remaining organs. So lungs is a remaining organ. So M3 anticholinergic. M3 anticholinergic drugs. So it can be beta 2 sympathomimetics or it can be M3 anticholinergic. Okay. Then under bronchodilators itself we have methylxanthine. So it can be methylxanthines. Actually, to be more precise, it is theophylline, which is the most common. And it has the most potent bronchodilator activity. We'll talk about this later. Okay. And we have Also we have steroids or corticosteroids. Corticosteroids. They are anti-inflammatory. Anti-inflammatory. Okay. Now, these are more or less bronchodilators, but there are other avenues of treatment as well, which I had mentioned. So let's talk about them. So we can cause, let's go back to that diagram. We can antagonize leukotrienes. We can make drugs which will prevent leukotriene synthesis. This is more or less what is done by steroids. Steroids actually will kind of inhibit the phospholipase A2, and the entire prostaglandins, leukotrienes, all those inflammatory mediators will not be produced. Hence, steroids bring about the anti-inflammatory action and are used in an inflammatory condition like asthma. So, steroids more or less they are anti-leukotrienes, you might say. But to be more specific, we have more specific drugs which only stop leukotrienes, which only antagonize leukotriene receptors. So, for that we have to make a separate branch, that is leukotriene antagonists. Leukotriene antagonists, right? Then we also have drugs which can stop the antigen antibody reaction, or which can make the mast cells stronger, so prevent degranulation, that is mast cell stabilizers. Mast cell stabilizers. And we also have drugs which prevent the antigen IgE reaction. Okay. So this is more or less the entire asthma treatment flowchart. All of these, they have different drugs under them, they work by different mechanisms, but you don't have to worry because it's pretty simple, it's pretty logical, and I think from the next video onwards we will actually go into the details of each of these. Okay. So I hope you understood the entire flowchart for asthma treatment, what the asthma condition is. I'm trying to make these videos shorter so that we can focus more and we can give a more detailed presentation of each of these. So thank you very much and catch you on the flip side.